Hello. Very good afternoon. A very good afternoon. Yes, that's the thing what I require, right? Usually post-lunch sessions are very difficult. Make you or keeping you awake is a task for me, right? So I don't know. It's always a coincidence with me, right? Wherever I go as a speaker or for a workshop, postprandial is my task, right? Is it because of my personality? I don't know. People think that he will also eat much and he'll not talk much. He'll also allow us to speak or sleep, right? But this particular topic, what I've been assigned for today, I think I'll try to keep you awake, right? After that Godi Hogi, it's very difficult, I know it, but still, we'll try to do it, all right? So before I start up, I am really humbled by the way Madam introduced to me, right? And also I'm humbled by the felicitation given by the organizing committee, and I'm very thankful for them for giving me this particular opportunity, right? So with this, I'll start with my topic, that is novel clinical trial designs, right? So when I got this particular title by Sir and other persons, and I should also take Dr. Chandrasekhar's name over here. When he talked to me about this, then I said, what are novel designs? And I was just taken away by what does this mean actually? Then I started doing some research and then found out, oh my God, there is something which I also don't know. I have to prepare for this. But the fact was, they were all concept based and they were revolving around what I learned as a UG and a PG. That was the final conclusion. I don't want to say it now, but you learn it and finally you realize it that, yes, this is what I know and I'm putting different ways to understand this. So I will take this session in two parts. Initially, I'll deal with the concepts, what you already know, right? I know that you people are writing a 100-mark paper on research methodology. You people are all thorough with study designs, right? With that background, I'll be just rushing out with all the study designs. And the second part, what I do is, I will help you to understand how I should choose a study design. You know it, you very well have understood the concept, but when I should choose it, that question will be revolving around everybody. That part I'll touch, and finally, I'll also not neglect this particular part. Novel study designs, bit of concept I'll be dealing with. These will be three parts of my talk, and I may not take more than 45 minutes. The number of slides may look more, but I'll be going through them at the earliest. And bet that I'll not allow you to sleep. Okay, right. So to begin with, so what are the objectives I just stated? I'll be just doing, provide a simple classification of different study designs. I'll be just telling you the examples for each study design, and we'll try to see that how I can choose an appropriate design to answer my intended question. All right. So what are the clinical questions usually? When we start with the research, we usually say that research question is a prime part, right? So how does this research question arise? Can anybody answer this? How do you start with the research? Or how does your clinical question or research question will come to your mind, that idea, right? Whenever your guide or teacher says that, bring some novel idea. From where do I get that novel idea? Yes, ma'am? Literature search, exactly. Anything else? I want my students to answer this part. Yes? Currently ongoing studies, exactly. You want to see what research is going on? Yes? Anything else? We'll just go through the list. So abnormality. When we will be dealing with a patient, especially I'll be speaking in clinical terms. So when I look at the person or a patient, I can say them, I will first my question, is he sick or is he well? What is the problem with him? So that is my question. What has happened to him? Right? All diseases may not be similar. Every patient is different. So the first question which gives to my mind is that particular person sick or well? Then frequency. How many times is this offering? Right? I'll take the example of COVID only. When first person got it, everybody thought something might have happened. But how many times it has occurred unknowingly? Right? Then everybody started thinking, oh, there is something different. And all of a sudden, for our lifetime, we learned that there is something called lockdown also. We enjoyed for 2 years, right? especially exams, passing without giving exams. That was the fun part of it, right? Every student will remember. So frequency, how many times, right? Then you look at the diagnosis, how accurate my diagnostic tests are, right? Are they testing what they are supposed to test? You say validity, right? What it is supposed to test. Is it doing that? Is my question or is my test regarding that particular question I'm trying to answer? Then cause. What causes this particular disease? What is caused for this particular SARS or COVID? Is it a virus? Is it a bacteria? Is it lifestyle? What? Virus. We all know the answer now, but when it started, we didn't, right? So we try to identify the cause. Then what are the risk factors associated? Now, sir, is the question, right, regarding the coronary heart diseases and cerebrovascular accidents. What are happening after COVID vaccine? What is the cause? Is it the lifestyle? Is it vaccine induced? Is it drug induced? Is it lifestyle? What? We don't know. We try to establish the cause. Or are we looking at the prognosis? Is my molecule which I am patented is going to help the disease or not? Right? Prognosis, how good the disease is overcoming. Then the treatment, is it helping it or not? Then finally, are there anything which I can do to do the preventions, right? And finally, we should not neglect this part when we are conducting the research. Is it affordable, right? I can say that I'll build Taj Mahal to everybody, but is it affordable? No, right? So just try to answer these questions. I think you will have an idea in your mind to go ahead with your research, right? This is the basics. Then the second question would be, what is a study design, right? When you plan to construct a house, what will be the second step? You got an idea. I have a 60-40 site. I have to build this. Now, what you do? You go to an architect or a civil engineer for the planning, right? So study design, I can always use the simile that it is the plan, how you are going to conduct your research. So what is the study design? It is nothing but a specific plan or a protocol. In your language, I can always say protocol. So it is a protocol which helps in conducting the test. And finally, what we do? We conceptualize the hypothesis into a operational one. You translate your idea into a implementable research, right? That is your study design. How am I going to do it? After my idea is there, I have framed a question. How am I going to answer the hypothesis? How am I going to establish the risk, or how am I going to confirm the risk? Is that okay? So that is answered by your study design. So what designs exist to identify or investigate factors in health-related events? Are there any designs you know about? Any study designs? Pop up. Yes? Any design, whatever you know. Yes? Observational studies, very good. Interventional studies, I just surprised whether my next slide is there or what. Okay. Observational, interventional, cohort, case control, cross-sectional studies, very good. Crossover designs, RCT, randomized clinical trials. Anything else? I think my job is done, sir. I should leave the stage now, right? So thank you. Thank for those answers. So we have basically division into qualitative and quantitative studies. So do you know what is qualitative and quantitative? This qualitative is, you are speaking about not the numbers, you are speaking about the characteristics. How, what color, what, how fat, right? Is it sick or not, right? You are speaking about something else. The characteristic is not a number. That is your qualitative, and quantitative is what we are doing in our day-to-day life. That is about numbers. You infer or you get the data or convert them into numbers and try to find out the relationship. This is how your study designs or types are classified. So I just wanted to highlight over here these things, right? Qualitative, you have ethnographical, phenomenal, grounded theory, historical research, case studies, feminist research, and action research. why I try to here is, nowadays whenever you are reading your journal articles, you always say that it's a mixed method study. Gone through this mixed method. It's basically quantitative, mixing it with qualitative. So what is this qualitative? Basically finding out the opinions of the people, what people think about this particular research question. If I want to introduce a preparation of iron for prevention of or treatment of anemia, what knowledge does people have? Do they think anemia is really a disease or not? Or do they have any strategies to deal with that particular anemia? Are they going to accept my molecule for the treatment? So that story you need to build up first, then try to answer your research question. That is a newer trend. What we are doing is a mixed method approach for answering your research question. Is that clear? Okay. So this qualitative research is nothing but, as I say, use words rather than numbers to describe the findings. So you listen to the stories. It's more of stories and narrations what we look into here, and we generate a hypothesis and try to answer it. So quantitative studies, I think you all know that it is nothing but you try to iterate or practice of building, refining or improving process where evidence is evaluated, theories and hypotheses are tested, and technical advances are made. Okay, now we got a clear picture about what is qualitative and quantitative. So what we do is more of this quantitative, where we are trying to evaluate theories and hypotheses and test them and also build upon some technical advances. So basically, as you people said, so we divide these qualitative designs into observational and experimental. Now my question is, what is the difference between observation and experimental? Yes? What is observational? The word itself tells you that it's you are just observing, right? Means as an investigator, you are just a spectator. You are just watching what is happening with the natural course of the disease. You are not doing any intervention. You are not intervening, right? So the basic difference between these two here is in interventional or experimental studies, either you put or remove something out of the natural process of the disease. Is that clear? In observational, nothing. You're just spectator. You're watching a movie over there. Whatever is happening, it's going on. But what happens in experimental? It's like a theater. You can intervene sometimes. You can say that, oh, you're doing something wrong, or you can just modify something. Is that clear? So observational, again, we classify them into descriptive, analytic. Now, what is it? Any idea? Exactly, sir. Describing is you're descripting, right? In terms of, I have it in the next slide. And in analytical, you're trying to analyze it. How, when, why, where, what is the association? How thick, right? In describing, you just describe it. Where it has happened, how it has happened, how many are suffering, right? All those answers you get in descriptive, and we have these designs in a observational studies. It starts from a case report, case series, and cross-section studies. When we speak about analytical, means to do some higher level of thinking over there, right? You're trying to analyze what is the association between these two things, the independent and the dependent variable or the outcome variable. What is that particular association? The relationship, what we are trying to do is trying to analyze it. And the designs will be case control, cohort, cross-sectional, and ecological. Is that clear? Now, experimental designs, we classify them into RCTs and non-RCTs. RCTs can be clinical trials, preventive trials, risk factor trials, cessation experiment, trials of etiological agent, and evaluation of health services. When it comes to non-RCTs, that is uncontrolled natural experiment, that is like before and after comparisons. I think that is a 5 marks question for you people. Everybody knows this by heart, right? Then trials can also be controlled or not controlled, and further controlled can be randomized, not randomized, and randomized can be blinded, or it can be sometimes not blinded. You know these terminologies, right? Okay. Now The US Institute of Health further classifies clinical trials into treatment trials, preventive trials, screening trials, diagnostic trials, and quality of life trials. A bit in depth about what they are. So treatment trials, they'll be testing experiment treatments, right? Just like your new molecule, what you give us, we'll be trying to find the answer to that. Then prevention, new ways of prevention of the disease in people, screening test, what best way I can detect that particular disease. What will be my test to identify that particular disease? Then diagnostic, what is the best procedure to diagnose it? And quality of life trials. Nowadays, these things are taking an upper hand because we also want how people are living with the disease or with the treatment or with the disability. And RCTs can be based upon the design. You have parallel design, your crossover design, your cluster design, and factorial design. I think you people are masters in that. I don't go in detail about that. Then, based on the outcome of interest, we can call them as explanatory trials or pragmatic trials. Then, based on the hypothesis, it can be equivalence trial, non-inferiority trial, or superiority trial. So, whenever we are doing, especially two molecules, whenever we try to compare, we always say that they are almost equal. So, saying the hypothesis that both the molecules have equal effect, we start, those kinds are called as equivalence. And the newer molecule is no more inferior. That becomes your non-inferiority trial. And sometimes you very well know that the newer molecule has a better outcome, then you can go for a superiority trial. So when you weigh the causal evidence, so it goes on, the temporality goes on increasing as you go higher up. So case report is single one. Once you are seeing the case and you are reporting, you are one drug molecule, you say that, oh, he got cured. So that cannot be established. You just say that, yes, it can. So those kind of things, case reports. When you're doing it in a series, some 10 patients or 12 patients, you observe and say that, yes, this is working. Those things appear to be in case series. Ecological is, they test the consistency. If the same 10 people, you do it in Bagalkot, you do it in Hubli, you do it in Belgaum, or in other states, in other countries, that consistency should be there. Then those things, we call them ecological studies. Dose response. How much dose is indicated, right? 1 cigarette causes lung cancer, 3 cigarettes causes lung cancer, is it 10 cigarettes causing lung cancer? Dose response. How much dose is required to cause the outcome, right? That is your cross-sectional. Case control, is it reversible? We took or try to establish the reversibility with a case control study, and cohort study tells you the strength of association, how thick is the association. And finally, clinical trials tells us the temporality. What is temporality? Koli madla, motte madla. Which one? So when we try to do a clinical trial, we try to answer this. What came first? Right? There are some cases where we cannot answer still date, but you remember that when you speak about temporality, what came first? That answer is given by your clinical trials. So time frame, if you just look, somebody said this, prospective designs. Many times we use it in our titles, a prospective study, a retrospective study. Please don't use them. They're not study designs. They tell us how the study is proceeding. Is it going ahead or is it going back in time? Okay, they tell us the time trend. They're not the designs. They just tell us how the study is moving ahead. That's why I put this. So prospective study, when you say that, it is nothing but it looks forward, looks to the future, examines future events, follows a condition, concern, or decision in the future. You're going ahead in times of time. Which is the example for this? Any idea? Which study design falls under this? You go in time, along with the time. For years together you do it. Your RCTs, randomized control trials. Today you start the drug, right? And you observe them in future, right? Your RCTs are your prospective studies. What are these respective studies? They look back. They look back in time to study events that have already occurred. So today, if I'm going to start the study, I go back in times, right? If I want to do a study on cancer, so lung cancer, I take cases of lung cancer today and I go back in time and see whether they were smoking. They can give the history, right? These are also called as historical studies. we collect the history and try to establish the association. These are called as retrospective studies. A very good example for this would be your case control study. So now, depending upon the direction, you have your cross-sectional designs, retrospective or backward studies, or forward studies or prospective designs. So, or ambidirection. Some studies go back and then forward in time. Okay. Before I go into the futures, further slides, I just want to test your idea or knowledge about association, because I'll be speaking only about association and relationships. What is this association? Can anybody define? What is association? You test the association, right? Whenever you are doing a molecule, you want to find out whether that molecule is giving a benefit or not. The outcome is going to happen or not. That is nothing but relationship. So how? What is this? What is this relationship? It just tells us the association between two things. For example, I'll give you a very simple example for diabetes. What is the cause for diabetes? Do you know why diabetes happens? Or I'll take much more examples, simpler example, hypertension. Why hypertension? Everybody should be, answer should be increase intake of salt. Everybody knows that, right? Is that relationship really exists? Salt intake and hypertension? Then the more and more there is an association between salt intake and hypertension. Or lung cancer is a very good example. Smoking and lung cancer, everybody's hey gidde, hey gade, most of the movies it shows, right? So some ulcers on the cheek because of tobacco use, right? So is that association really exists or not? Right? You want to test it, and we test it by different study designs, right? I'll take one more example. How many years course is yours? 6 years, right? Usually I tell this story to my medical students, right? Whenever I speak about association. What happens when you come the first year? What happens? So you all come together, right? Boys, girls, all to come together. There will be a freshers party, interaction, everything to happens, right? And there will be some dirty minds also in the class. Agree with me or not? Some boy talking to the girl, and this dirty mind starts telling, oh, what is that? What is that? There is some lafda. Okay? This is an observational study. You observe both of them and say that there is some lafda. Okay, so you hypothesize. Observational study, what we do? We hypothesize, right? There is some association. When it happens second year, you all pass first year. Second year you come. What starts? Both that boy and girl start walking to the cafe, to the canteen. They are together in the practical halls. These dirty minds, pakka le. Agree with me? Right? And in the hostels, you start discussing about it. Right? This is your case control study. We go back in time and try to establish the relationship. Oh, allu idru, illu idru. So you come and you test your hypothesis saying that yes, the association exists. Third year, right? More career oriented. Now they are not in the cafe, they are in the library. Yappa, library bandarle. Right? Now the cafe has converted the relation to study relationship, much more thicker. You confirm it. Right? So that is nothing but your cohort design. We go ahead in time, right? Whether both of them will pass or not, whether both of them are going to the same company or not, same industrial interviews they are giving or not. So you observe them throughout the time. That is your cohort design, right? You go in terms of time. And finally, what design is left? RCTs. So what do you do in the RCT? Huh? Do you have internship? Yes, right? So internship, what happens? At the end of the internship, if they get married, oh, the association is real. Isn't it? It is proved. If it doesn't happen, may or may not, right? Every relationship ends up with marriage. Many a times, no. Isn't it? So when do the RCT at the end of the internship, if it doesn't happen, then we say that the association was spurious. What is spurious association? False association, right? Or something, it may also happen that in internship, we all were thinking that A will marry B, but C has come between and married. Right? So this is indirect association. All these days, C was fielding for A. This discussion do happen in the hostels, right? Fielding right? So this is how I usually take up with the study designs and association. Forget the story, remember the study designs only. All right. So when I speak about the direction, so we should always remember cross-sectional is one time. You both look at the cause and the effect at a given point of time, single point of time. Case control, going back, whether the history was there. Cohort, going further in times of time, you try to look at the association. Okay. So observational, you'll just try to do this. The first thing first, right? You'll be trying to describe. Most of your long questions, right? 10 marks questions. Describe. So what do you do in describe there? When I say describe the mechanism of action of so and so drug, everybody will be When I say describe Aishwarya Rai, how do you do that? You have different headings, right? Similarly, you can follow for our study designs also, right? So what you need to do is description. When it comes, you type answer these 6 questions. If you have seen textbook of Park, community medicine textbook of Park, so there is a sentence over there in the first chapter. I always carry the 6 men with me. Who are they? Why, when, where, how much, which. If you try to answer all these things, I think your descriptive study will be done. Where it is happening, why it is happening, how it is happening, who are affected, which group is affected. If you can describe this, I think your descriptive study is done. So the concerns over here is, it is concerned with following questions. That is TPP, I call it as time, place, and person. So cross-sectional study, as I said, yeah, I'll just jump with this. So it is just not a cross-sectional, right? One time. You just look both, the hen as well as the egg. Both you will be looking at the similar point of time. That is cross-sectional study, right? If you go to the field, the community hodaga, you'll see both, right? There will be eggs as well as hens. Now you start asking whether the hen or the egg or the seed or the plant, right? But both of them are available at a given point of time. That is cross-sectional. Cut. Right? So both will be seen. The risk factor as well as the outcome. Both will be seen in a cross-sectional design. So analytical, as I said, you try to analyze. You try to look for the evidence for the association. The cause and the effect, you try to look at the evidence. That is nothing but your analytical study designs. So I said there is case control study as well as there is cohort. So case control, what we do? We go back in terms of time. The outcome has already occurred. The disease has already occurred. Then we try to find out what the disease has been caused by, right? What happens in cohort? The disease has not occurred. We have a group of people. Then we follow them for a period of time, see the risk factor, then the outcome, right? This is again the same. Then this interventional study. So in interventional study, the researcher manipulates the situation and measures the effect of manipulation. This is where your roles come, right? So all these were more of epidemiological study designs, I call them, or community study designs. When it comes to interventional studies, it happens in different phases. I don't speak much about the phases, I think. You all are very much well versed with phase 1, 2, 3, and 4, right? What is phase 4? Post-marketing. There where these things come, right? Your cross-sectional design, case control design, descriptive design, all those things will be implemented over there. So usually, but not always, 2 groups are compared, one in which the intervention takes place and the other group remains untouched. The cases and the control, or what you call the interventional group and the control group. Intervention where you are doing the manipulation of the intervention and the control is untouched. So basically, we divide the international designs into experimental studies and quasi-experimental studies. So what is the difference between experimental and quasi-experimental? So when we say experimental, it should fulfill three criteria. What are the three criteria? To call it as an RCT, randomized control trial. One is randomization. Other two. Sorry? No. Blinding should be there. I don't agree much upon the three basic things over there. One, I said is randomization. Two things you need to find out by the end of this session. Use your Google phone or something, but try to find out, because I want to give it as an assignment to you. If I say you don't remember it, right? That's always a teacher says in the class, whether the answer is known or not. But that really helps you to learn, okay? So what happens in quasi-experimental design? The randomization is missing and a separate group. Okay, so when we speak about RCTs, randomized controlled trials, or any study which has a comparison, the comparison is very important. So you know, no, what is comparison group? There are two groups. Why we always have a comparison group? Why comparison is required? To say that I'm fat, you should compare with me to somebody else, right? Then only you can say that. You can say that my coat is much blue. When you say that, when you compare with the other blue, right? I'll tell you one more. Everybody heard about Akbar Birbal, right? Who are they? Nowadays, this question should be asked to the children. They don't even know Akbar Birbal. We were all like, Akbar Birbal Kati andre very important for us. Akbar Birbal, you know, right? Okay, Jodha Akbar, everybody knows. That way, I have to, motivate this. So what happens is, how was Birbal? You know about his characteristic? Very intelligent, right? Hapana, you know, Akbar was very much depressed. So when he came to the court, the assembly, Birbal saw Akbar was very much depressed and almost sitting like this. Then he said, Jahapana kya hua? What had happened? Then Akbar said, see, my son is crying the whole day. I am unable to console him. Then Birbal said, what's the matter? I can do that. Right? Then Akbar says, you are the most intelligent person. How can you do that? And I know that you can do it. Can you help me out? Then Birbal asked, okay. How is that possible? Others started thinking, Jahapana couldn't console his son. Being the great of the country cannot do that. Right? That question started revolving around, and they said, how can we do that? And the question was, Jahapana's son wanted a big piece of good. Good, you know, right? Bella. Doddu piece bella beku. Jahapanaಗೆ ಏನು ಕಡಿಮೆ ರೀ, ಎಷ್ಟು ಬೇಕು ಬೆಲ್ಲ ತಂದೋಗ. ಬಟ್ ಮಗು ಅಳ್ತಾನೆ ನಂಗೆ ದೊಡ್ಡ ಪೀಸ್ ಬೆಲ್ಲ ಬೇಕು. What to do? Who will answer this question? Then Birbal came, right? Then he said, okay, I will console him. Everybody started in the assembly, right? Ministers, ದೊಡ್ಡ ತಗೊಂಬಂದಿಟ್ರು ಹುಡುಗನ್ ನನ್ಗೆ ಇದು ಬೇಡ, ಇನ್ನೂ ದೊಡ್ಡದು ಬೇಕು, ರೈಟ್? ಇನ್ನೂ ಒಂದು ದೊಡ್ಡ ಪೆಂಟಿ ತಂದಿಟ್ರು, ನನ್ಗೆ ಇನ್ನೂ ದೊಡ್ಡದು ಬೇಕು. ಲಾರಿ ತುಂಬಾ ತಂದಿಟ್ರು, ನನ್ಗೆ ಇನ್ನೂ ದೊಡ್ಡದು ಬೇಕು. Birbal said, how can we do this? Then he brought two pieces of small pieces and one big piece and hold it in front of the boy. And yes, pick the bigger one. Right? So what is the answer over here is comparison. So we always need comparison to say that whether our molecule is better or not. Is that clear? The importance of comparison or comparison group in all your study design is because of this. Many times you say that why should we take a comparison group, sir? 1-to-1 comparison, 1-to-2 comparison, 1-to-4. Why these statisticians are behind us to have more number of sample size? The answer is to say this: how good is my molecule, or how good is my intervention, or how good is my molecule, right? To answer that, we need to have a comparison. So that comparison or control group is missing in quasi group, right? And we don't randomize, we don't have a comparison. That becomes a quasi experimental group. When you have all the three, I said already two. One, you need to find me out: control group or comparison group, then randomization, and one more. If all three are there, then we consider it as a experimental study. Okay. So I have some activity before going ahead. So I want you to see how much you people have understood. I may or I may not. We'll just have some questions for you people. Try to answer them. So this is a case story. I'll just read it for you. Cases of viral hepatitis are monitored by the DHO in the district. Each case of viral hepatitis is indicated by dot on the map. He also records the seasonal variation. He classifies the cases according to age, gender, occupation, source of water, supply, and other personal attributes. This is the hypothesis or a story. Now you need to find a study design for this. How do you answer this question? Which study design? What are you doing over here? We are trying to describe the disease in terms of age, in terms of gender, occupation, source. So what would be the design? Yes? Descriptive design. Very simple. You are trying to only describe. So when you are asked to describe, or when your mind is thinking only how is happening, what it is happening, then your answer for the design should be descriptive studies. You're not intervening over there. Okay? Then to assess the proportion of geriatric population in rural area, you want to see how many geriatric population is there. What should be the design? Are you doing an intervention over here? What you do? You just count how many are there, or you just observe how many are there. So what should be the answer? It is cross-sectional or observational. On the larger end, it is observational. If you go, it is cross-sectional. So it's a big question, right? Test the hypothesis that children of separated parents are more likely to become drug addicts. So what I want to see is separated parents. The parents who get divorced, their children are getting drug addiction. So there is already a hypothesis. There is already a description. I want to find it out, right? So what should be your answer? You're analyzing, right? So basically I can say it is a analytical study. You're not describing, you're analyzing. So under the analysis, it's a case control because they're already addicts. The kids are already have addiction. So you go back in time and find whether the parents were separated, right? Got the point? Okay, we'll skip this. Yeah. How many new cases of measles would occur in 1 year among infants in the community? What are we going to find over here? How many new cases of measles, right? So what are you doing? You're going ahead in terms of time. So what is that? Cohort study. Yes. So the very interesting part of cohort studies, you can try to find the incidence. How many times it is occurring. Okay. Okay. So this was a study which I did. The test whether 300 milligrams of oral clindamycin 2 times per day for 5 days administered at 13 to 20 weeks of gestation in women with vaginal pH of this reduces the incidence of preterm delivery in Karnataka. So what is my hypothesis? My hypothesis is I want to test 300 milligrams of oral clindamycin. For what? What should be the outcome? Outcome is to decrease preterm deliveries. So what should be my study design? Am I only describing the event? No, I'm intervening, right? I'm giving 300 milligrams of oral clindamycin. So this is a experimental design. Everybody agree? So among the experimental, can we still further go and do something? It should be an RCT, right? Randomized control trial, because I should have a group for comparison that 300 milligrams I don't give to them, and what is the rate of preterm deliveries. Those who receive 300 milligrams of clindamycin, what is the rate of delivery, right? So this should be a experimental design. So it can be RCT, it can be double blind. So somebody said me the word blinding, right? What is blinding? Masking, right? Nor the investigator, nor the participant, nor the analyzer knows about what intervention is going on. If the participant doesn't know, it is single blinding. Participant and the investigator, double blinding. The person who is analyzing also doesn't know, it is triple blinding. So the third thing what happens in RCT is blinding is important. So one more study. This was again brought as a national guidelines for prevention of postpartum hemorrhage. So to determine heat stable carbetocin is not less effective than oxytocin when used in vaginal deliveries as heterotonics. What we do is, right, oxytocin, it has heterotonic action, it reduces the bleeding. Okay, so something similar to that was carbetocin. The advantages of carbetocin is it is heat stable. Oxytocin is not heat stable. You all know, right? It is not heat stable. Carbetocin is heat stable. So in prevention of PPH, we tested these two molecules, oxytocin and carbetocin. So what should be the design? Is it observational? No. It should be experimental, right? Okay. Under the experimental, RCT, because we need to have a comparison group, or we need to have two groups. One is oxytocin, other one is carbetocin. If I want to look at the equivalence, then what should be the study design over here? If I am saying that both the molecules are equal, or one is superior or one is inferior, so we need to look at the experimental, RCT, double blind, and non-inferiority hypothesis. I mean, for oxytocin, carbetocin is no more inferior in prevention of blood loss, right? This is how we structure the design and try to answer your research question. We go back to the main one. We'll continue with our study designs. Got right? What is case control? What is cohort? What is experimental? If you get these basic ideas, I think my purpose will be served. Okay. Then what are these clinical trials? I'll go into a bit deeper part of these novel designs now. So this clinical trial is a clinical research study which are done to determine whether a new drug or treatment are safe or effective. I think the whole purpose of our research is this, right? With a newer molecule or whatever molecule you have, you want to test the effectiveness or whether it is having safeness or not. So these are the different advanced clinical trials designs. So what is the difference with what we are existing doing is, in contrast to traditional designs, they test a single drug in a single disease, isn't it? Whenever doing a study or RCT, what we do, we have single drug and single outcome. But now what modifications we are bringing the protocol is single drug, many diseases, many drugs, single diseases. Those options we are going to test. Okay, so what are these novel clinical designs? We have something called as adaptive designs, we have master protocol design, and we have platform trials. Heard about this? Heard? Read about them? So we have something modifications in the existing RCTs only, right? So they are adaptive designs, master protocols, and platform trials. Now, what are these adaptive designs? So adaptive design is defined as a clinical trial that allows modification to the trial or the statistical procedure after its initiation without undermining the validity and the integrity. So when you write a protocol, when you are trying to test the hypothesis, the design should be validated. The integrity of the design should not be lost. Okay, so withholding those things, if you are trying to modify something in the protocol or the design, that kind of design we call it as adaptive design. So clinical trials will be more flexible, efficient, and fast, because we have rigid protocols, right? When we write a protocol, we should follow it religiously. There should not be any change, right? Dina mani olaga barbekadre chappal bit barbekandre bit barlebeku. Do we deviate from that? Jalka aದ ತಕ್ಷಣ ಇವತ್ತಿ ಹಚ್ಕೋಬೇಕಂದ್ರೆ ಹಚ್ಕೊಳ್ಳೇಬೇಕು. Do we question it? Such should be the protocol. Protocol should never be questioned. Once you write it, it should be followed. Before writing, you have hundreds of literatures. But once you write it, no deviation at all, right? But these adaptive procedures or designs, they help us for flexibility. When we see that this is not happening, we can always try to modify in a adaptive design. Then the advantage is it increases the probability of success for your new therapy. It maximizes the information from the trial. It reduces the overall developmental cost, and it reduces the risk for the study for volunteers, and no protocol adjustments are required. I'm just saying you people again and again, no adjustment to the protocol, right? You're not deviating from the protocol. You're doing some adaptations in the protocol. Those things are called as adaptive designs. So the disadvantages, it is sometimes difficult to control the type 1 error. So what is this type 1 error? There are two types of error, right? Alpha error and beta error. What is alpha and beta? Very confusing. It should be written only before the exams. You go to the exams, you read it and go, then only you'll write it correctly. You come out, you forget it. It happens, right? So now revise what is alpha error and what is beta error. Okay. Now the design in adaptive design, what it is, this is our traditional design, right? You have a design, you have to conduct it and you analyze. This is what we follow now traditionally. What is this adaptive? You have design, you conduct it, you review it, you adapt the changes and again you analyze it. If you want to do any changes, if it is not happening something the good way, then you can always review and adapt. This is the difference between your traditional design and a adaptive design. Then there are different types of adaptive design. See, the list is so big. The adaptive designs are so big. So one is for the randomization, for the sequentiation, for the sample size, to look at the dropouts, to look for the dose findings, to look at the biomarkers, switching the designs, to look at the hypothesis, to look at this phase 2 and phase 3 and multiple adaptive designs. So everywhere you can bring about some changes and reform your hypothesis. Those are nothing but your adaptive design. Is that message clear? In newer articles, what we are finding is these adaptive designs. Then what is this? Master protocol. So this design, it says that the design includes multiple subgroups and multiple sub-studies. In the main protocol, you have multiple subgroups. That means you stratify. Stratification is nothing but grouping. Grouping according to the age, grouping according to the occupation, or grouping according to the gender. You group them, you make subsets, and you try to study them. Then sub-studies. If you find out, yeah, this particular molecule also has some other effect. So you can have a subset of it and try to look at that outcome also, right? So these are adopting or they're justifying for your groups and studies. And the patients having same or different diseases. If you are seeing that this particular molecule is working for two different outcomes in the same patient, right? You can look at the outcome for both of them and one or multiple drugs. So 2 drugs, 3 drugs causing the same outcome, you can adapt in this particular design and we call that as a master design. And there are 2 types in this, basket type and umbrella type. So when in the basket trial, what you do, the drug is one, the outcomes are different on different conditions. So you're looking at colorectal cancer, thyroid cancer, breast cancer, some other cancer, but it is a single drug, right? So that we call it as a basket. Then what should be this umbrella? It is the single drug, different subsets. Under one umbrella, you are looking at the different things. So these are called as master protocol drugs, where you can have different groups and different drugs studying on the same group of sample. And last one is a platform trial. It referred as a multi-arm, multi-stage MAMS design trial, right? It tries to evaluate several interventions against a common control group and can be perpetuated. So you have a common control group, you have different intervention group, one single common, we call it as platform trial. So you can just read out and I'll be sharing these slides to you also. So now, if you just basically understand how exactly the study design or research follows is, you have case report, one observation, why this particular suffering, one case, then similarly many cases, then you try to describe them, then you look into the laboratories or in the animal studies, then you try to find out the relationship either through cohort, case control or cross-sectional, then you try to establish the relationship. This is how the flow of study design happens. Now, which study design to choose when? Right? This is the basic question or a biggest question everybody first has to answer. Yav study design choose ಮಾಡಬೇಕು. So the best answer is go to the experts. Why should I break my head? Right? Go to the statistician or go to the epidemiologist. They will help me out. No, but we should know what am I doing. So this part I'll be trying to address which study design to choose, right? So there are certain questions which we have to ask ourselves as a researcher. My first question should be, alter the event under study. Am I going to alter or allowing just the things to happen as it is happening? Right? Will you be intervening or not? My other question is, am I just observing or am I doing some manipulation or doing some intervention? If yes, then you go for experimental design. If you are saying that no, I'm just a spectator, I'm not looking into anything, I'll be just observing, then you go for your observational study. So the second question you have to ask is, in the observational studies, am I going to look it for one time or am I going to follow him for period of time? If it is one time, it is cross-sectional study, right? If I am going to observe it for longer duration time, then it becomes a longitudinal study. Longitudinal study are either your case control or cohort studies, because you are going to have many visits, right? Then the next question is my interest only to describe a phenomena and not to study any exposure outcome or cause-effect relationship? I'm not going to look at, if I'm going to answer cause relationship, what should be my design? Or if I do not have any specific hypothesis, I do not have any hypothesis at all, I have never thought anything. Hypothesis is generated through when you find that relationship, right? Hypothesis is generated to a descriptive study. You make a hypothesis by a descriptive study. So if this is yes, then you do a descriptive study. If no, then you go for a analytical study. In analytical, again, if you are saying that I am looking at the effectiveness of a treatment modality is yes, then you do the experimental study. And if experimental study, then I have to see whether I am going to do the randomization or not. If I am doing the randomization on the individuals or is it on the groups? If it is on the individuals, then it will be your clinical RCT. If it is on the group, it will be your community intervention or cluster RCT. If it is no, then am I looking at the efficacy of a diagnostic procedure, or am I looking at the risk factor, or am I looking at the prognosis? Then it becomes your diagnostic study design, or it can be your risk factor study. It is cohort, case control, or cross-sectional. If it is prognostic, you look for the cohort design. So this is the basic picture. You go on answering each question, you can come to a conclusion. So selection of the design. Prevalence, we always go for cross-sectional. Incidence or prognosis is cohort. If it is etiology, case control study. If it is efficacy testing, your answer is RCT, right? So what does your design depends upon? So it basically depends upon the type of question, what are your goals, what are your beliefs and values, the researcher's skill, and the time and funds. If you have all these things, then you can choose an appropriate study design. So it's also related to the existing knowledge, occurrence of the disease, the latent period, and availability of the resources. So second, I can always say that study design is a second important component of a research. Then what is the first important thing? What is the first important thing? Design is plan. To have a plan, what should have? What should you have in your mind first? Research question, right? Research question is very important thing to start up with the research. And second important thing is your study design. So to conclude, I can always say that drug development is transforming into innovations in clinical trial designs. Everybody agree with us? In recent years, adaptive enriched designs have seen a substantial increase in use. So there is a mixed method way, there are adaptations, there are master protocols. We want to do a lot of things in a small period of time. So these adaptive designs and master protocols, right? Then clinical trials requires more complex design to increase the efficacy and effectiveness while maintaining high quality data. So the very aim of us is to generate high quality data with things in mind as ethically, right? The previous session was ethics, right? To generate data is very easy. To generate that ethically is very important, right? Don't forget or don't ever compromise with ethics, right? With this, I think I'll conclude my study. I think I made my purpose of two things. Thank you. Thank you. I just amazed with the sound of the claps, right? I don't know for what, for completion or appa sakappa bitta. I don't know which one is the answer, but I always take it positive, right? So it was for my best one, I think. Okay, right? So before I go for the question, I should really thank the organizers for putting a lot of efforts in these things, right? The theme of the conference is so beautiful, right? It brings in so many different things which are very, very important for your career. For you people to get into industries, the sessions are very important. The first session started with ethics. The second session, I don't know how much important was it for you, but it is important when you start your career. And tomorrow's sessions also, I saw it in the schedule. They are very important. They really help you to guide yourself into building up your career, right? Inculcate them not for only exams, for your career development. This conference is aiming towards that, if I believe, sir, right? So this is for that, and I hope the organizers have done their justice in doing this. Thanks and big clap for the organizing team, and thank you. So can I take the questions, or do you have any questions?
Now the session is open for doubts. Feel free to ask.
Silence is the answer. So I can say thank you. So your questions are always welcome. You can post it them to your teachers. They can always do that. If you are not willing to ask it now, I am happy to answer them later also. I am a social media freak. I am on WhatsApp. I am on Insta. I am on Twitter, everywhere. Right? You can always find me with my name, and you can pose the questions. I don't mind in answering. All right. So that nowadays is the way to answer the questions. Nobody asks the question in the class. It's always through WhatsApp, always through Facebook or Insta, whatever. Use them for the better way, right? Thank you. And again, I thank everybody for the patience.
Although we couldn't hear the session backstage, we could hear the delight and excitement of the audience back there. Thank you so much, sir, for conducting such an enthusiastic and informative session. I request you to please come forward to accept a small gesture of gratitude. Respected, respected principal, sir, please bestow this honors on our speaker. In wrapping up this engaging talk on novel clinical trial designs, let's remember that innovation and flexibility are key to advancing healthcare for the benefits of patients and society.
Moving forward to the third session of the day, I call upon Dr. S.K. Nimbalsa, Professor and Head, Department of Pharmacology, to introduce our final speaker, Dr. B.R. Jaidev Kumar, Sir, Department of Pharmacy Practice, J6 College of Pharmacy, Mysore.
Good afternoon, one and all.